Welcome to today's Crisis Jam. I'm David Covington. I'm the CEO and President at RI International and today's host for the Crisis Jam. And we're thrilled. Melinda Baldwin from SAMHSA. We had an opening and she scrambled last minute so she could give us an overview of the new national guidelines for children and adolescents. So, really looking forward to having her present today as we move forward. This community continues to grow. We have about 350 to 400 on the call each week, but about 150 of you are coming really frequently, and that remaining group is coming from a much larger community of over 2,000 actually. Karen, I'm seeing a number of folks mentioning audio interruptions. Are you able to hear me okay, Karen?
Yes, you're coming through clearly for me.
Okay. So if you're having challenges, don't hesitate to text Karen Jones and she'll work to find out what's going on. But this learning community continues to grow. We add about 25 a week and are nearly at 2,500 on the community overall. We continue to try to make it as accessible as possible through the talk.crisisnow.com landing page, where you'll find the Zoom link. Some of you, I see it notes occasionally, well, it wasn't on my calendar. Well, we moved away from a calendar entry. So now you can just go to the talk.crisisnow.com learning community landing page. You'll see that Zoom link that you can use or share. You can also, if you want a calendar invite, sign up for our weekly reminder newsletter. And within that weekly reminder, you'll see an element where you could add something to your calendar if that was something that you thought would be helpful, as well as seeing what today's presentation is. So we're constantly updating that list. And then we've got all of the recent videos, the recent presentations, as well as the featured segments of Trivia Hot Seat and quotes and more on the website. But we're finding that over 100 of you each week are missing the call, but then watching the video on YouTube and catching up. So again, all of those resources are there. We're continuing to build that out as we go forward. In the news, the momentum around media coverage of crisis care continues to grow. Really exciting set of articles in the Los Angeles Times, also in the San Diego Tribune, featuring this no guns, no badges, no sirens. Again, a similar approach to what we've seen in media coverage of the CAHOOTS model over the last couple of years. But this in a dedicated mental health crisis approach, more akin to what's outlined in the SAMHSA national guidelines. This particular article features the telecare folks and Exodus Recovery, both providers who are predominantly in California. And Karen, if we can drop that link into the chat. Lawmakers face pressure to pass mental health legislation. I include this from roll call. In particular, because it includes quotes from our own learning communities, Sarah Corcoran at Guide Consulting. So Sarah, perhaps you can make a comment about this when we get to your update. And finally, Dr. Mark Reagans was a featured presenter in Crisis Jam a couple of months ago now, and talked about even at the point of extreme crisis, we ought to be engaging around folks' hopes and dreams. And really key components of the ideas of recovery, psychiatric rehabilitation. And if you follow Stacy Friedenthal, she's a Denver-based suicide prevention expert and researcher. She tweeted out this article in the Washington Post, a meaningful life is possible amid suffering. Some therapists say, Stacy's tweet was, don't all therapists say that? Certainly they should as we go forward. Really exciting last night. Dr. Mike Hogan emailed me and said, when's the last time we had a president reference lean into mental health crisis in a national address? This quote from President Biden last evening: let's get all Americans the mental health services they need, more people they can turn to for help, and full parity between physical and mental health care. Perhaps the last time we had a president speak about crisis care in this way may go back Certainly, President Kennedy, at the beginning, crisis care was one of the fundamental 5 pillars of the Community Mental Health Construction Act. And really exciting to see us, as President Biden said, fight for mental health in his speech last night. So let's get straight to our featured presentation. Melinda, one of the key sort of interest in the learning community over the last few months has been more content around children and adolescents, and a focus. We'll have Tim Marshall coming up in a few weeks. But the work you and your team have been doing at SAMHSA to release guidelines specific to children and adolescents is just terrific. So tell us about it.
Oh, thank you so much, David. And thank you for having me. This is such a wonderful time for everyone to gather and to talk about these important issues. So I'm Melinda Baldwin. I'm the director of the Division of Prevention, Traumatic Stress and Special Programs. And that's the division at SAMHSA where we have a lot of the children's discretionary mental health programs. So thank you for having me. Next slide, please. So as David mentioned, we've been working very hard on the national guide for children's crisis care, building a children's crisis continuum, which we hope will be a best practice toolkit that will be very helpful to those of you in the field setting up specific crisis and mobile response services for children, youth, and young adults. So we based the work that we're currently doing on SAMHSA's National Guidelines for Crisis Care, a best practice toolkit. And as many of you know, this advances national guidelines in crisis care within a toolkit that supports program design, development, implementation, and CQI efforts. And it's separated out into 3 essential elements: someone to call, someone to respond, and somewhere to go. And we're taking a very close look at each of those elements and how they may be adapted to better serve children, youth, and families. And we felt that this was very important because that toolkit focuses on adults, but how can we modify it for children? And many of you will recognize this graphic as SAMHSA's vision for a redesigned crisis system. And so this is where we started. We started with a toolkit. And this visualization is how can we think about this in the context of children? Because as we know, the juvenile justice system, child welfare systems, emergency departments can often have harmful and detrimental effects to children, youth, and their families, and exacerbate an already intense crisis situation. Next slide, please. So this is the background of what we've done to pull this toolkit together. We've had a whole series of listening sessions with families, youth and young adults, SAMHSA grantees. We've been and spoken with the NASHBIT, the state mental health program directors, also the children's directors, and a whole host of other folks within the government, some of the grantees over at the Administration for Children and Families as well. We held a series of 3 expert panel meetings, and some of you on the call were so helpful and participated with us, where we actually deconstructed the toolkit and looked at the very specific items that were targeted towards adults, and then talked through how they should apply to children. And, you know, as often when we schedule these meetings, we schedule them for 3 hours thinking they'll be done in 2. And I need to tell you that every meeting, and there were 3 of them, folks stayed the entire 3 hours with no breaks. So very committed group of individuals. And so some of the grantees we talked to were the Systems of Care, our AWARE grants, which are our school-based grants, our clinical high risk for psychosis grantees, and our statewide family networks. So I want to explore and share with you some of the themes that we discerned from all of these listening sessions with the folks in the previous slide. So the importance of family and youth peers in this work, and this is at the top for a reason. This came up repeatedly as being one of the most important things that needed to be included. The focus on crisis prevention. that folks wanted to develop services within the community so that crises didn't happen, and if we could prevent that as much as possible. That a mobile response was dispatched when the caller, meaning either the family member, the youth, requested it. So having them define what a crisis was and when they needed someone to come out to their home to help resolve it. That a response and services needed to be equitable, accessible, trauma-informed, developmentally appropriate, and culturally appropriate. That staff needed to be trained in child development and family systems. And this is staff at all of those three different categories of response: someone to call, someone to respond, and then a place to go. Child and family serving systems and supports. This information was critical in responding to callers. Also, and this came up just earlier in this call, that specialized areas such as youth and family engagement, de-escalation techniques were critical skill sets that staff members needed to have. And they needed to be connected with their community so that families and children saw them as trusted members of their community, someone that they felt comfortable calling when there was a severe crisis in their family. We also heard a lot of concerns. Next slide, please. Folks are worried, we have a warm line, we have a response team. How are we going to connect that with 988? And how is that going to work? Because, some felt that the warm line was working well for their community. Others had some struggles with it, but the intersection was really important to people we talked with. What's going to be the financial impact? Will our states and communities be able to afford the services necessary to make sure this is a success? Is my community able to meet the increased request for response? Because everyone we talked to felt that this was a very good idea. Their community needed it, but how could we make sure to respond appropriately, especially in our rural communities and frontier communities? They were concerned about the lack of their own community-based services, especially respite, feeling that respite was key, especially in working with children, youth, and young adults. There was a lack of trust in the current crisis system, and often that had been perhaps with a police response or other kinds of response that had not gone well. And so a lot of our families talked about that lack of trust and worry that would continue with 988. Workforce shortage, and we're all very much aware of how this is impacting the social service system writ large, but especially in this space where trained and skillful staff are so important. There was also a concern about safety for mobile staff going out on calls and the callers themselves. They wanted to be sure that the response was not the same for children and adults. And there was also concern about consent, especially if a young person was calling without the knowledge of their family, and how would guidance be issued for all of those different circumstances. They also wanted to be sure, and this came actually very strongly from the youth that we talked to, is they wanted to have a robust data collection system with outcome measures so we could see if it was working. And if it wasn't working, that we would be open to going in and tweaking the places where we needed to. And of course, the much needed coordination and partnerships with schools, police, hospitals, and emergency departments, and how that was key in making sure this all was successfully implemented. Next slide, please. So what I've done today, and just so you know, we have finished all of this work, and the document is put together, and we are in the process of revising it. We've sent it out to everyone that was involved. They've submitted their feedback to us. And so now we're revising, and we hope to have it completed by the end of next week. And then it will go up through the SAMHSA and HHS clearance process. But what I'm sharing with you this afternoon is some of the things that we have discerned that are coming through in terms of minimum expectations and best practices. And what we did in putting this document together is follow the outline and the setup that was in the SAMHSA Best Practices Guide. So you'll be very familiar with how it's laid out. So you can see here some of the themes in terms of best practices for someone to call. And when we think about someone to call, and there's even a little telephone there, we want to expand that because youth talk to us about how they feel more comfortable often in texting or using a chat feature. And so that telephone is kind of the old-fashioned way we think about a crisis line, but I want you to think about it as more expansive than that. Again, the importance of peers. Rapport with a person with lived experience may be critical for children and their parents in crisis. An opportunity for a warm handoff from parents to the services, and consider to use parent-peer partners for these roles. The call response should be a 24/7, 365-day a week enterprise. With whatever backup would be needed to happen, that we would coordinate very closely with mobile crisis teams to maintain specialized knowledge of child and youth development and crisis presentations, maintain knowledge of child and youth and family-focused de-escalation techniques, making sure all of this is implemented within a trauma-informed systems approach, and to focus on crisis stabilization from the inception of the crisis contact. Another theme was transportation, that often coordination is needed depending on mobile crisis team recommendations, and especially when we're talking about rural communities. And that connection to services. So making sure that the linkage to mobile crisis teams with specialized training and knowledge of youth crisis and stabilization is there in each community to respond to calls. And that information and access and same-day follow-up with psychiatry and other types of clinical services is available. And then there's coordination with systems such as child welfare, residential placements, to not only prevent crossover, but if those placements are necessary, that service delivery is consistent and that everyone is informed of what is happening. With services that they're recognized and coordinated. And they're also understanding that there's also a lot of social determinants of health that can impact a crisis, make it worse, and really being able to connect with those services in the community. Communication, as we talked about, that localized text and chat is the best practice for young people, and that should be administered locally through a hub that's integrated with the local behavioral health system, and ensure that any kind of screening instruments that are used are normed to children, youth, and young adults. Next slide, please. And so with someone to respond as the second leg of this three-legged stool, we also separated things out between minimum expectation and best practices, which you can see here on the screen. And they involved a lot of the same themes, just as, with the mobile crisis center. So in terms of transportation, to resolve transportation without the use of law enforcement or emergency medical services whenever possible. And if screening is necessary, making sure that intervention for children in crisis is different and that needs adequate attention and resources. The role of peers was very important in this stage as well. And then services, that the family system is acknowledged and that there's recognition for the needs of non-traditional family systems. And that resources are here so those mobile crisis services are robust and that are unique and can respond to that uniqueness of a child in the context of their family. So in somewhere to go, next slide, again, separated out into the same minimum expectations and best practices, is here are some of the themes that we saw here. And I need to preface this by somewhere to go. Just the title of this section raised a lot of discussion because this may lead one to believe that a child is being removed from the home, either to a child welfare setting, a juvenile justice setting. And so everyone that we talked to wanted us to very carefully think about the title to this third leg of the three-legged stool, and to think about how we could frame this for children. And thinking about in-home stabilization, the emphasis on somewhere to go disregards the need for these services. So want to be given the opportunity and support to stabilize a child in the home and keep the child in the home wherever it's safe to do so. And if there can be in-home respite and services immediately following the crisis. If a parent arrives at a crisis center, follow-up care should reinforce in-home and crisis de-escalation and stabilization. And that follow-up continuum is critical to establish in-home skill building and knowledge dissemination so parents can learn and hopefully prevent crises in the future. Again, the role of peers and is critical during this phase, and the coordination with a psychiatrist and healthcare providers to make sure that that's an ongoing service available to the child and family. Next slide, please. So there was also, we will address concerns with rural and frontier communities, people with intellectual and developmental disabilities, people with autism spectrum disorder, early childhood concerns, especially parents with young children. And then at the other end of the developmental spectrum, those transition age youth and young adults. And so that is just a brief synopsis of what we're planning. I would love to be able to come back when this document hits the street so we can get your feedback and talk more about it, because, you know, it's one thing to look at a slide, it's another thing to be able to look at the document. And so please reach out if you have any questions. I haven't been able to attend to the chat, but I see a lot of dialogue going on. And so I'll ask David if we can get a copy of that to make sure we include that in our feedback. It would be most appreciated.
Yes, Melinda, thanks so much. Terrific and really thoughtful and engaging connection to a lot of stakeholders as you put all of this together. This is going to be really powerful and key. And Karen, let's make sure we get the text chat to Melinda to introduce into this work. So we've got Tim Marshall coming up in a few weeks as a featured presenter around the Connecticut child and adolescent crisis system. Tim, you're our first up in the roundtable today to give us a quick reflection on the work that SAMHSA is doing to craft individualized guidelines for children and adolescents.
Yeah, thank you very much. And thank you for the invitation. And thank you for the presentation. I missed the first few minutes, like first 4 minutes. So my apologies to that. But I just want to say the planning that we've been doing in Connecticut, really, we've been in the thick of things since the unfortunate Newtown tragedy. And so we had a number of legislative bodies that have been meeting routinely over the years. But obviously, in the last few years, some of the work that body has been doing got really spring-forwarded to the forefront. But I also want to say that the work that Connecticut has been really facilitated by SAMHSA grants. We're currently active system of care grant. We've had many in the past. We have a current AWARE grant. We have had multiple suicide prevention grants, Garrett Lee Smith grants, and we just finished the 988 planning grant and looking towards the implementation now. And we also just have used in our planning the best practice guides that SAMHSA put forward. And this sounds, Melinda, like a great addition to those materials. And it's really structured our work in Connecticut really well. So this whole issue of, somebody to talk to, somebody to respond, and a place to go to has just been really fabulous for us. we're right in the throes of really doing some big enhancements that we'll talk about in April, including standing up kind of the urgent crisis center, the 23-hour assessment as an alternative to the emergency department, an accompanying crisis stabilization unit with that. We're also looking, Connecticut has had a robust and really wonderful mobile crisis system where we have both a specific child service mobile crisis and an adult. And we're really working on enhancements there. The big ones there, again, driven by best practices, suggestions out of SAMHSA is one, moving to 24/7. We are mobile 6 a.m. to 10 p.m. right now. So we're moving that to full 24/7. And then the other big ones we're looking at is the geo tracking and the real-time appointment scheduling. So it's great material, great opportunity here, and just appreciate the opportunity and look forward to coming back in April. So thank you, Dave.
Yeah, Tim, terrific. Thanks so much. And look, there was great feedback about your presentation with the states. And so we'll look forward to bringing you to the Crisis Jam to talk about Connecticut. And of course, our Assistant Secretary was the mental health lead there as well before coming to SAMHSA. So look forward to that. Melinda, the chat is just blowing up. So lots of interest in this peer parent thing that you were talking about. My ears perked up when you said that. It seems so simple, and yet I've not seen or heard that exact concept talked about. So one other thing, Rep. Orwell's asking about a couple of things here, connections to the K-12 system, and then example of tween and teen crisis centers. So Dwight Holton, you're on the call. You're going to be in the crisis trivia hot seat in a few minutes, but can you say just 30 seconds or a minute about, because you've networked both Lines for Life and what are there, about half a dozen teen specific, including here in Phoenix. You want to talk just quickly about the teen centers that are out there?
You bet, David. There are a half a dozen teen to teen crisis lines that I know of. The Arizona folks, Teen Line down in Los Angeles, and Youth Line here in Oregon. There's an outfit in Washington and in Missouri, and there's one other that I'm missing. But these teen to teen peer services are really remarkable, and together I would say talk to about 75,000 young people in all 50 states every year. I know most about Teen Line and Youth Line, and together we talk to about 60,000 young people in again all 50 states. It's teens who go through 60 hours of training. They're closely monitored by master's level clinicians, and especially during the past 2 years, as young people's support networks have been disrupted, they've been there, right? As coaches and counselors and teachers and friends at school have been ripped away from these young people, those teen lines have been there. And we're really looking at a situation where 18% of the people who call the Lifeline are under the age of 25. That's about 350,000 young people. We're looking to build a capacity so that we can meet that need with teen to teen peer delivered service.
So look, what's clear in the text chat, and it's been a theme in this Crisis Jam, is that peer and family supports and designated roles within the crisis response system are going to be key to the future of this. So that's really terrific. Hey, let's go to Kirsten Baranio. Kirsten, obviously a senior policy leader at CMS and now with NABH, has a really unique perspective and understanding of all these issues. Kirsten, as you're hearing the guidelines from Melinda and the conversation going on, what are your reflections?
Yeah, thanks, David. I think it's wonderful that SAMHSA is focusing on this population. I think there is a really strong need to do so, and all the things I heard that all the issues that they're thinking through are really important. I would add a couple of issues I worry about. It's just how quickly that we need these services and facilities, and how long it takes to build up like brand new facilities, and the lack of funding for construction and all of that. So I really just wanted to highlight the need to partner with existing provider systems and communities. As I think Representative Orwell mentioned, Shepherd Pratt has programs, for example. A lot of existing behavioral health providers have programs. beyond just the existing warm lines, there are programs that can be leveraged and built on in more of a short-term way to address some of this need. So I did want to emphasize the importance of that. I totally agree with the need for in-home stabilization services, but frankly, given the workforce issues we are facing right now, we really need to be realistic about what we can do in the short term and really building on existing programs. But at the same time, recognizing the need for a special setting for young people to go to if that is what they need. So I do really echo the comments that were made there around needing a place to go that's really very focused on children and youth. Just one other quick thing I wanted to highlight that I don't hear a lot of discussion about in these conversations of crisis services is the importance of telehealth. Telehealth has been critical during this pandemic, and there's just been so much progress in terms of implementation and coverage, but we all know a lot of that, there will be a lot of pressure to pull a lot of that coverage back. So, I see telehealth as a critical way to leverage existing workforce to help fill the gaps, some of the gaps in workforce, and really improve access, and including in crisis situations. However, there are certain policies in place now that require an in-person visit, for example, in the Medicare program, that we fear, even though maybe not directly applicable to children and youth, is going to have likely be taken up in other coverage programs, state Medicaid programs perhaps, or commercial, that really will impede the utility of telehealth in crisis situations. So those are just a couple of quick thoughts.
Great comments, Kirsten. Build on the existing capacity and really begin to drive this forward. Love all of that. There's a comment in the text from Maryland about the launching of statewide mobile crisis services. And look, this may be one of the most powerful alternatives. And then, Kirsten, what you referenced around telehealth, clearly, even our 911 emergency medical response system isn't as available to tribal country and territorial America as it is for the rest of us. So these are great solutions to be reflecting on. Debbie Atkins, I'm interested if you have just a quick comment. You were part of that Georgia development of a statewide system responding to not just adults, but children and adolescents. Any quick comment from you, Debbie?
I think it's very valuable. Wendy Tigreen is actually on the line and is part of the system now. Wendy, if you want to come off and comment for DBHDD, that might be more appropriate.
Hi, everyone. Good to see you. I just want to echo what Kirsten was saying in terms of some practicalities related to a children's intervention, and try to give us the space to evolve into this, because it is so crucial having the child-centered models, and while also understanding that we are launching this in a huge way, right? And in Georgia, we've had mobile crisis response for both adults and youth. And again, I've mentioned on here before, and IDD as well as addiction, all blended in. And so we have to have these multidisciplinary teams. We have to have a lot of flexibility related to workforce, particularly in our rural areas where we just don't have the capacity. And so I think having this as a standard that we all work towards operationally is going to be crucial, but also not putting too much restriction and mandate on states in the early implementation stages so that we can grow into this. So I could spend a lot more time talking about some of those unique dynamics, but I will leave it at that. And Debbie, thanks for the kickover, and to everyone, SAMHSA and David facilitating today. This is really crucial conversation, and we've got to be family-centered in this whole evolution.
Love all that, Wendy. Structure with the freedom for states to take some unique approaches based upon their individual circumstances. So great conversation, Melinda. We'll look forward. Maybe John, during the SAMHSA update, you can give us your over under on when these SAMHSA guidelines will be approved. I'm assuming next week sometimes, John, these will be approved through the clearance process and out for publication.
You know how things move so quickly. I mean, it probably will be tomorrow,
Could be
'cause
tomorrow.
things move so fast.
So we had Dwight Holton. Dwight, come back. Dwight is a former state's attorney for Oregon and the executive director for Lines for Life. And we heard a little bit about Lines for Life. Dwight, you're in the hot seat today.
Oh man, I'm telling you, I don't know how I got roped into this, David.
No trepidation. We are increasingly raising the heat, as you know, trying to split the audience for these questions. Today's trivia question: the diseases of despair. Case in Deaton a few years ago began to reflect on a uniquely American challenge of increases in suicide, opioid overdoses, and alcohol-related deaths. In November of 2021, even more than what they talked about, the CDC reported drug overdoses have now topped 100,000 annually, unfortunately. But of those 100,000, only 5 to 7% are officially recorded as intentional and therefore as a suicide. But in 2019, Dr. Joshua Gordon, NIMH director, stated in an article, some experts estimate up to blank percentage of opioid overdoses are actually suicides. So is that A, 10%, B, 20%, C, 30%, or D, 40%? So we're going to give you some audience help here.
Good.
Audience, if you'll jump in, we're going to give about 10 seconds. We typically have a few hundred of you respond to this, but if you'll just hit your answer and click submit, we're going to wait a couple of more seconds and we'll give Dwight the benefit of the audience feedback on this.
Good, I appreciate it. I tell you, David, this is something, as many of you, as those of you who know me know, I came to this field from a different field, from criminal justice, and I came here because almost everybody in that system is there because of untreated addiction or mental health. And one of the things that you have taught me is this unbelievably important link between suicide and substance abuse in the form of despair, and that the answer is hope. It was an evidence-based strategy. So I appreciate that learning from all of you.
So Dwight, what do you think the audience is going to pick on this?
I am betting the audience says 30.
So let's see what the audience says. The audience says 30. We've got 20 as the next, and then between 10 and 40, the next two answers. Dwight, you can go with your gut on this. You can pick the audience, or you can quickly phone a friend. What's your thought here?
I want to phone a friend, David.
Yep.
I want to bring in Rusha Grinstead, who is responsible.
Yeah, Rusha, are you with us today?
I am.
What do you think, Rusha? Rusha is our great state partner on this effort in Oregon, down the Willamette Valley for me, David. What do you think, Rusha?
I'm going to go with 20%.
So Dwight, you've got Rusha weighing in with 20. You've got the audience weighing in with 30. Your gut seemed to be 30. And you went with Rusha instead of a researcher. I gave you a suggestion to go with a researcher, Rusha, but Rusha knows her research too. So what's your thinking, Dwight? Final answer, Dwight.
I'm going to go with Rusha. I'm going to go with 20%.
So look, what Josh Gordon wrote is 30%.
Man.
There have been a number of folks. Mike Hogan, I've heard Dr. Mike Hogan talking about this for, 3 or 4 years, and he's always used about 30 to a third. But Josh Gordon was referencing work from Maria Quendo. Ian Rocket has done work in this area, and all of them come down about the same place. However, Dwight, we are going to give credit to 20%. I talked to Thomas Joyner last evening just to pressure test this. And what Josh actually wrote is estimate up to, but the over under on this is tough, right? This is likely between 20 and 40%. It could be as high as 40, but it could be lower. We don't know for sure. Our best guess is 30, but it's a push. And it's a push because if somebody doesn't make their intentions known, then we don't know. But the Michigan ED study found that almost 40% of those presenting with an overdose reported wanting to die and not caring about the risks. Another 15% reported they were unsure of their intentions. So in the pre-call to this meeting, Aisha, you were talking about intentionality. Love for if you haven't already dropped that text in here. But Dwight, Rusha, we're giving you credit on that. The ultimate, Dwight, is the issue of there's a lot of overlap here of pain. And even when it's not an intentional suicide. I think what Case and Dayton brought us was this overlap of alcohol-related deaths and opioid deaths are, again, ones that we're wanting to support people in the life-saving work that we're doing.
And David, I'll just add that, you know, as we look at our work in community engagement in communities of color, we're talking about suicide has been taboo. We're starting to think about whether or not other indications, like people who say they don't care if they live or die, ought to be fitting into that suicidality box.
Yeah, of course. Great. Rusha, great to see you. Thanks for joining. Dwight, great work.
Thanks, David.
Okay,
Thanks,
so
Rusha.
let's go. Stephanie Hepburn, great to have Mary Sowers back with us again and Crisis Talk this week.
Yep. So Mary is the executive director of the National Association of State Directors of Developmental Disabilities Services. And Mary shared that behavioral health crises among IDD populations only represent a small fraction of overall psychiatric and substance use emergencies, but they're often high impact. Mary, if you're on the line, if you're on the call, if you said that IDD specialists don't need to be on the 988 center call for per se, but that they do need to be dedicated co-location and connectivity. Can you talk a little bit about what you mean?
Glad to do that, Stephanie, and thanks for having me today back. Essentially, you know, recognizing, as you just said, that the numbers of individuals with IDD who might present for the crisis line might be small numbers, their impacts can be extraordinarily high. And so rather than sort of having someone on the floor necessarily, but it's important to have that capability on call. And so in each of the states in the District of Columbia and the territories, there are experts within the state agencies, within a number of partner agencies and providers that can be extraordinarily helpful in helping to mitigate a crisis as it's going on. So making sure that those linkages are established early, that there's designated individuals with a geographic coverage area, that can really help have someone sort of on a lifeline, if you will, available to the 988 crisis line that can help sort of walk through and help mitigate those problems and really try to problem solve with the individuals. And it may well be that there's folks that maybe communicate differently. There might be some expertise with particular diagnosis that would be extraordinarily helpful. And so, you know, we're hoping that in each of the states in the District of Columbia, that every, as the 988 structures are developed, that those linkages with the IDD systems, and when I say the IDD systems, I mean both the state agencies within the state, and also there's a cadre of really wonderfully funded projects like the Developmental Disabilities Councils and the University Centers for Excellence in Developmental Disabilities, who have expertise in these areas too. So there's a kind of a great resource available across the country that can help the 988 crisis lines really sort of make sure that they've got access to some of the expertise that they might need on the drop of a dime.
And you mentioned not just at the 988 call center level, but also for mobile crisis.
Yeah, absolutely. For mobile crisis. And frankly, even as individuals present in hospital ERs, making sure that those resources are also well known and available for law enforcement. There's really making sure that across the spectrum of crisis supports, there is that linkage and familiarity across the systems, really, to ensure that there's that opportunity for collaboration.
Thank you, Mary.
Mary, thank you so much. Thank you, Stephanie. And look, Wendy Tygreen was talking about the integration of substance use, mental health, suicide, IDD. And Mary, let's continue to make sure that we're bringing this work forth in the Crisis Jam. We'll also have Dr. Carol Olson in a coming Crisis Jam. We'll talk about the challenge of comorbid serious medical issues and crisis that we've not really addressed in this jam to date. So expect that coming soon. So next up, John Palmieri. Wow, what a week! The President's State of the Union and SAMHSA continuing to drive forward.
Yeah, thanks, David. Yeah, really happy to be here. Appreciate everyone's participation and partnership. For most of you who probably did catch some of the State of the Union, obviously very pleased that the President, as part of his unified vision around mental health and substance use concerns, really promoting and disseminating a broad strategy to address these concerns at the national level. For those of you who have not seen the strategy, a fact sheet that's on the White House website. We can definitely provide a link to that. But really, I mean, as David said at the top of this hour, really a unique moment to really provide some increased visibility on needs that all of you have been very aware of and advocating for support for. And so, really appreciate that this kind of culminated in a unique moment last night in the State of the Union address. Within that fact sheet, as many of you probably have already seen, there is some signaling for approximately $700 million in funding that will be supporting 988 and crisis services more broadly. There will be obviously more details associated with that funding amount when the president's budget is released, which we're expecting will be later in March. And so we'll be able to provide more information and probably address more specific questions at that time. And then also wanted to flag that related to the dissemination of the strategy and the address last night, there is a briefing for partners to discuss the strategy at 3:30 this afternoon Eastern time. And for those of you who don't have the link to that, again, happy to put that in the chat. And that's really open to anybody who wants to attend the briefing on the strategy. And then I'm going to hand it off to Richard, James, anybody else on the call from SAMHSA.
Thanks, John. I don't think that Judge James was able to join us, so I'll just mention a couple of things, just obviously echoing John's excitement about the President's Unity agenda, including mental health, and the way in which 988 Out is called out in the fact sheets. So this is an obvious, quantum change from the past that is extraordinarily meaningful, moving forward. I will just mention a couple of other things. I want to acknowledge and commend my colleague Melinda Baldwin for all the work that she's doing on the children's, crisis continuum. It was great that Tim Marshall from Connecticut was able to be, weighing in. I think Connecticut has a wonderful system for children's mobile crisis outreach, which among other things is not only well funded by the state, but really links into and provides enhanced quality improvement efforts and looks into times when really that system, the mobile crisis system, can be used rather than needing to utilize 911 and the police. So I think it's just a great best practice for people to look to. And I'll just mention one additional thing, because it came up before in the conversation about opioid overdoses and how many in fact are suicides, which of course we don't know for sure. And as you said, David, the issue is that if somebody doesn't leave a note or hasn't communicated intent to someone, there may be one name, but there may be no way of knowing for sure. But one of the issues that it wasn't framed in this way, but I think is important, is to be aware of the distinction between what's called active suicidal ideation and passive suicidal ideation. An active suicidal ideation, I'm thinking about killing myself, I have a plan, etc. But passive suicidal ideation is more like what was referenced before. I don't care whether I live or die, right? But one of the important things to know about what's referred to as passive suicidal ideation, and it's not all precisely defined, but some of the research that's out there suggests that the long-term sequelae in terms of death for suicide is as strong for passive suicidal ideation as it is for active suicidal ideation. And of course, those who have what are called passive suicidal ideation may really have active suicidal ideation, but are reluctant to express it in that way to others. So very, very important areas. And again, the link with substance use and abuse is so important, for many reasons, but one of which is that it's almost impossible to completely disentangle this.
Love all of that, Richard. Eitan, you have a comment reflection.
Yeah, no, and just building on kind of what John and Richard shared, and David, your comment in the chat, I just kind of want to reinforce how it hopefully should be an amazing opportunity to provide dramatically deeper and wider investments in the crisis system. I mean, just thinking about, Richard says this all the time, but where we were 18 months ago at 24 million from the Lifeline, and now thinking about 700 million for 90-day and broader crisis services, I think it's a testament to all the folks on the line who do an enormous amount of good work in the crisis space and the White House's vision that there will be a lot more resources to bring to bear here. So I think that there's a lot of strong energy and excitement around that, and appreciation as well.
Amen, Eitan. And thanks to you, Richard, your decades of leadership in this space, John, you and the Assistant Secretary and the entire team putting us in the position for what we saw last night and this ongoing work. Thank you so much. Brian, with the NASBID update, I think we're going to go to Arlene for a quick update.
Thank you, David. Good afternoon, everyone. I wanted to give you an update on the paper I told you a little bit about last week. It's called Our State's Experience in Legislating 988 and Crisis Services Systems. It is available now, and I'll tell you how and where you can find it. But before I did that, I wanted to say thanks to Laura Evans and to Matt Taylor at Vibrant for their guidance in this paper, as well as the staff at NASBID, Christy Malik and Millie Ezekiel, who supported me every step of the way on this. The paper actually provides a summary of the legislation that has been developed for 988 through the end of January of 22. We had to cut it off somewhere because it's like a moving target. It encompassed about a half of all of the states in the country at that point. And to the extent that information was available, we described three other things in the paper, and one was financing mechanisms that they're using. Also, the interface that they may have been working on between 988 and 911, and any obstacles that the states encountered in trying to get their bills developed and passed. So you will find the URL for that in your chat box, and you can also find it on NASBID's homepage under What's New. And I have one other thing that is also finally finished that I had mentioned last week, and that's the 988 model bill. The update is available finally, and there's also a set of corresponding PowerPoint slides that go along with it. And those are also on our website and in your chat box.
Terrific, Arlene. And Brian, wow. I mean, I believe, Brian, every single state that has worked on this has started with the model legislation that NASBID led putting together. So just tremendous work, Brian.
Yeah, I agree. And I want to give Arlene a lot of credit for her leadership on this. So thank you, Arlene.
Thank you, Arlene. Terrific. Let's go to Sarah Corcoran. Sarah, you watched the State of the Union last night. What's going on at the federal level, Sarah, that we haven't already addressed?
Yeah, thank you, David. And if we can go to the next slide quickly, I've got two quick updates. In addition to all the great updates from SAMHSA and earlier on the State of the Union. On the FY22 appropriations front, the House has announced that they are planning to vote on the FY22 omnibus collection of the rest of those appropriations bills next Tuesday. That's the announcement of when they plan to vote on it in the House. We have not seen the text yet, so we do not know what the levels are, but it's likely lower than the bills that we saw earlier in the end of FY20, but still looks like it's going to be remarkable investment in mental health and substance use funding. On bill introductions, just a quick flag that the Cardenas 988 implementation bill is set to introduce actually on the 8th next week on Tuesday. Eric is going to drop, if he hasn't already, his contact info in the chat. If any organizations would like to endorse the bill, they are looking for more endorsers, but it's already a pretty impressive list. So it doesn't hurt to double check to make sure your organization is on the list if you've already thought you might have been on it. So that's coming up in the next week as well. And we'll hear more from Eric next week on the bill, but that is it for me. Joanna, do you want to talk about committee hearings?
Sure, yeah. So today, the House Ways and Means Committee is hosting a hearing on substance use, suicide risk, and the American healthcare system. I believe it actually might still be ongoing at this point. It started this morning, so I tuned in for a little. It was really encouraging. It's the 6th hearing in 30 days in the House and the Senate on these topics, so it's a really great indication of how committed Congress is to confronting these issues this session.
Terrific, Joanna. Thank you, Sarah. And we'll look forward to having Eric briefly on the call next week to give us next steps on the bill. Terrific. Do we want to start with Hannah or Steph? Are you with us from NAMI today? Hannah or Steph with us?
Yes, this is Steph. Hi, David.
Hey, Steph.
Yes, so quick rundown of some state updates. We can start in West Virginia. Senate Bill 181 has passed the state Senate, but I should note it actually underwent a few significant changes in the Finance Committee before it passed that chamber. Some of the financial provisions have been taken out, most notably the 11-cent fee provision that was in there. The bill still contains a provision on developing reimbursement for crisis stabilization and receiving centers, however, and financing has sort of shifted focus to funding 988 in the state budget bill. Also with Kansas, there is a substitute version of House Bill 2281 available. The major changes there were lowering that 988 fee from a 50-cent level to 20-cent level, greater clarity on also what that fee can be paid for. Mississippi's House Bill 732, which creates a state 988 commission, has passed its Senate committee. So we expect to see that on the floor soon. And also just noting in Washington, House Bill 1688. So this is all about health insurance coverage requiring behavioral health crisis services to be covered by state regulated health plans. So another important financing component. That's already passed one chamber, and last week it cleared the Senate Ways and Means Committee. So positive news out of Washington.
Great, Stephanie. Thank you so much. Laura, are you with us for a quick update from Vibrant? Anything else you would add?
Yes, I'm here, and I think Steph covered all of the updates, so I don't think there's anything additional to add on the state side just yet. Thanks.
Thank you, Laura. And look, you see the little buttons for the states where we have these stat cards. If you've passed meaningful legislation in your state and you don't have a card yet, then outreach us. I think Kim Myers is working with some of you to get some more states up here. We already have Virginia, Utah, Nevada, and of course, Washington State was our first one that we've got, and all of these are on the learning homepage. We will have more next week. The calculator that we've been talking about is, I've seen a version of it moving and working, and we hope to unveil this by March the 15th, which will really give you the ability to, in a map, click on your state, on specific counties, and get an estimate of the crisis capacity you need, it real tangibly and discreetly for mobile, for crisis receiving, and to see estimated costs and the diversion, the cost avoidance that you can create through using this Crisis Now sort of model. Keep bringing your attention to the Moving America's Soul on Suicide series. We've been highlighting Tanja Miles, who's been a frequent contributor in the Crisis Jam learning community. And in coming weeks, we'll be dropping the Dr. Thomas Joyner video, who I referenced earlier. We did an interview with him. A couple of quick webinars that Karen will drop into the text. One from the American Ambulance Association around the implications of 988 for 911. I believe that's actually later today. And also NRI and SMI Advisor, we've talked on these calls about the issues of peer support specialists who have prior justice involvement. And there's a webinar, we'll put that into the chat text as well. Finally, next week, Dr. Henry Harbin on standardized billing for crisis. This is a key area. How do we go from, instead of having a state-to-state solution, having a set of national, the guidelines give us the expectations. How can we begin to scale these services across the country? So thanks for joining us today, and we hope to see you next week.